Hey Kendra, can I ask you something? This is the PEPC meeting, right? Oh, good. Other people are joining. All right.
Can you actually, is his microphone working? Oh, it is.
Yep. I hear you.
You might hear other stuff in the background too. I've been trying to do these on Thursdays with us right before a scanning shift. So we try to do these from the ED. You look nice, Rosemary. How's everything?
Good. Good. I post overnight, so a little extra effort to bring the jazz. I'm like, come on, wake up.
And I can't do anything post overnight anymore.
I know. I didn't have the heart to switch the shift, so I was like, oh my God, okay, I can do it. I'm usually a total spaz, which is my first disclaimer for this talk. Henry's not on here. That's why I was a little nervous before.
Fashionably late. He's logging in now.
Hi, Rosemary. Sorry I missed your call. I was putting my kid to sleep. Yeah, sorry.
Oh, good. I was like, I'm the only one in this room. Am I in the right spot?
Yeah.
Oh my God.
Wrong spot.
Wrong spot. How's everybody doing?
Good. How you doing? You told me you were overnight, right?
Yes.
You look well rested. I was up because my kid is teething, so he's been up all hours. So that's when I realized that. Yeah,
How old is
that's when I
your
realized
baby? I mean, small child.
One. It's 3 months.
Oh.
I think they're coming in, but yeah. So.
Brutal.
Hi, everybody.
Who was that?
Hi, it's Eric. I'm taking a break from Rapunzel. It's 7 p.m. my time.
Oh.
And so I'm just, I stepped away from, my boys are watching Rapunzel before they go to sleep. So that's why I've got my video off, and I'm hopefully far enough away from the TV that the music won't bother everybody.
I presume everybody's volumes have picked up?
Yeah, we've been busy this week.
Mm-hmm. Ghana, I mean, I think for us, early March, because gone are the days where I'm checking email on shift. Or like I'll do that, edit that document stuff. There's no more editing of nothing.
Same here. And very little of it is COVID.
Yeah. Well, we still have that, but there's other stuff too. I think with I don't know if it's our area school openings or whatnots. And the weather is getting better.
Well, by us, the schools, the the younger kids have been back in school since for about a month now. The older kids are still not back.
Mhm.
So, so I don't know what it is. It's really just in the last week and a half that all of a sudden we've had this jump in our volume, and most of it is, I mean, most of it's actually trauma now.
Interesting.
Mhm.
You know, maybe it's just the weather out here is getting a little bit better, so more kids are outside on their bikes.
Mhm.
Our psych volume has been insane. It's
Did
like
you say
half our-
psych?
Our
Psych?
psych just like
Yeah.
crippling. It's like half our unit will be full. I had one shift like a few weeks ago that we had like a 16-bed unit. I think I had 17 psych patients and was like in the waiting room, just like doing public service announcement and trying to like not violate HIPAA, but basically tell people you're all here for psych. It's all going to be a long time. So like hunker down and don't do anything foolish. Like, which luckily was received fairly well. So
Wow.
That's lucky. I mean, I think in the last couple of months, my ED has been averaging 30 psych patients. We have our own separate unit, but they still outflow into the main ED, and it's just crazy. So
It's really sad. Yeah.
Happening here too.
Who was that?
Oh, it's Julie. Hi.
Julie.
Yeah, no, I just came in. I just signed in and heard you guys talking about the mental health volume. It's so sad. Where our half of our ED is just boarding. Henry, we're gonna set up a site in between our two EDs
that would be awesome.
for boarders.
Yeah, if you can get that going, Julie, that would be fantastic.
I'm on it.
Yeah, because it is crazy. But you guys send them upstairs, right? Like we have no time limit in how long they can stay in our ED. So some kids have been there for like a couple of weeks, and I don't know. I would go insane in the
Yeah, no, we have that too. We can't send them to our floors.
Oh, you can? Okay.
No, at
Wow.
Brown they do. They send they I think at Brown half of their, I don't know Eric if Erica's here, but half of their floor is just boarding.
Wow.
We can't do
Yeah.
that.
Wow. You guys must have seen that Columbus's fancy building. Their entire psych, what is it called? Big Lots Psych Unit or something. It's like the 7th floor, massive, gorgeous, state-of-the-art building just for psych. It's amazing.
Whenever I hear those stories, I just get jealous, you know.
All right, let me know when to get started.
Yeah, we'll give everyone 1 minute, and then I think then we can all go. And Eric, if you're still on, I just sent you an email regarding next week.
Right.
I should have sent it earlier. It's my things that didn't hit send for some reason. So
I'm looking at it right now.
yeah. All right, Rosemary. So good afternoon, everyone. So this week we have Rosemary from DC who will be presenting to us. So thank you again for presenting to us, Rosemary. And get away where you want.
Yay. It's a pleasure to be here. I'm so excited. I've watched and learned so much from you guys. So I'm happy for the opportunity. And those of you who've done this, you realize, you can't see the chat. So would love to hear stuff out loud, snarky comments and et al. So please don't hold back. So we're sort of among family, right? So that's why I'm sort of excited about this. You can see, yes? Screen sharing is in effect.
Yes, we can see.
Excellent.
Mhm.
All right, so let's see if this is my first 2 disclosures are that 1, I'm post overnight, so I hope that I represent myself in my most closest to normal form. And 2, the earrings, no, that's not my closest to normal form. And the second is that I haven't been able to join you guys for 3 out of 4 Thursdays of the month, because that's when all our faculty things are. So if you discuss cases like this and you're like, that was so last week, I'm sorry, I don't know. So you're just gonna have to go with me on these. And that's it. So our first case is a 10-year-old male with, oh, and the other thing I would say is that I chose the cases, as we probably all do, for either they're just interesting to look at, or maybe for management and how you go about something. So some of it's just interesting, some of it's like discussion. So I have a 10-year-old male with hemophilia and factor VIII deficiency, and they say it's like moderate. 5 days ago, developed right hip pain and thigh pain. And mom actually gave him his factor replacement 3 days ago. And now he has 3 days of left hip pain, occasionally radiating to the groin and left testicle. So mom's usually able to tell when he has a bleed because he has bruising, but not this time. And he's ambulating, but sometimes it limits his activity. So on exam, he doesn't have fever. There is tenderness to palpation of the soft tissue lateral to the ASIS. And there's full range of motion of the hips, but pain is elicited at extremes of motion on the left, specifically with abduction and rotation and the testes. So you're a POCUS person, and you know, I specifically love MSK ultrasound for all things, because I think it really helps dispo sort of right away. Yeah. Right hip. And this is the of the asymptomatic hip. So nothing too much going on over here. Left symptomatic hip. And for the learners on here, right? So this is the acetabulum, the femoral head, neck, the synovium, and here is the synovial space. Here's the capsule. So nothing in that joint essentially. And so then on. And that's what you see. What do you guys? At this point, we're in the thigh, like just lateral to the femur. Thoughts?
Looks like you've got myositis.
Myositis. Anybody else?
Muscle looks like it's got this hypoechoic area that's, it's, you know, it's edematous. It's got this hypoechoic area that just looks like blood, maybe.
Mm-hmm.
Yeah.
Mm-hmm.
Yeah, maybe also hematoma.
Yeah, that's what I was going to say. Yeah.
Mm-hmm. Mm-hmm. So I put color on it. And it wasn't lighting up. So I took this to mean along your thought lines of it is hematoma. Yeah, hematoma. And I you know, and I was working with a fellow at this time, and, you know, that's how I was like, look, we dispoed this kid right away. I talked to hematology and they were like, oh, basically give him his vial of Advait and then, instructions for what to do with the second dose of factor at home, et cetera. And he was discharged home, and it was all pretty quick. And so rather than, getting a comprehensive, does he need more imaging, et cetera, the guy had like barely any pain, but we found this. And so I was like, this is why he has his left hip pain. It is not his testicle. It is not the joint. We don't need to do further things. So it was just a.
Rosemary,
Mhm.
can you go, it's Stephanie, how are you doing?
Hi.
Can you go back to the images? I'm just want to get a better idea. Where's your probe? Where are you scanning?
Right. Let me go back to here. So this is very lateral thigh. So it is sort of like fleshy part. So where he was most tender was like the anterior superior iliac spine, like around there. So the lateral thigh, exactly lateral, the femur, you can start to see here. So it's lateral to that.
Gotcha, thanks.
Mm-hmm. And this is in the two different planes, so transverse and long.
Rosemary, did you measure it? Just I mean, the only thing is,
I
had
don't know if
patients
I have a
come
still,
back.
but I think it was about like 3 cm by 3 cm.
Okay.
Actually, we can sort of see it here-ish. So yeah, about 2.5, 3 cm. Mm-hmm.
And just one more question. So are your specialists generally or routinely feeling confident with your scans? I know that if we did this at my institution, I feel like they would ask us to get a follow-up study in radiology.
Yeah, I think we've been around long enough that they are fine with it. I would say that in our institution, the three studies that we do comprehensive for are things that generally need intervention, such as appendicitis for surgery, pyloric stenosis for surgery, and intussusception for reduction. So for those three, even if we diagnose it, they will do a radiology comprehensive. But for most other things, including joint effusions, they're fine with, most of the other specialists are fine with. And hematology specifically is really knows us really well, because for all these sicklers and things, like we often are diagnosing acute chest before the x-ray, and the kid is sort of borderline. We're trying to decide to stay or go. And based on our focus, they'll be like, let's keep them. So
that's a nice use of POCUS for diagnosing acute chest.
Mm-hmm. Yeah,
I'm being facetious.
Rosemary, this is Lay from New Haven, Connecticut. I really think this is a great study. I think in a few minutes you've ruled out the most feared complication, which is hemarthrosis. Once you know that the fluid or the bleeding is not in the joint, then you're done. And that's
yes,
really a great use of the focus modality.
Absolutely, which is why it's so simple. And I really, it's funny, when we teach our fellows, we are a lot focused on cardiac fast, abdomen, cardiac fast, abdomen, but like MSK and of course soft tissue. MSK, I feel like it's the buy-in is easier. They can understand how it's helpful for dispo and patient care, because a lot of times they're like, why do I really need to do the scan sometimes, but MSK is really money. Any other thoughts on this? We'll go to the next case. All right. And also, it's weird. I usually do Google Slides or, but for some wacky reason, I decided to do PowerPoint, and I'm like, wow, this is so clunky. Okay. So our second case is a 2-year-old female who fell outside while she was with her grandmother, and mom is the one who brought her here, and she's not sure about any details. The kid is holding her right arm at her side in abduction and pronation, and there's no swelling, and she's just like sitting there staring at you. So another great time that I use POCUS a lot. Right, so I think I only have, oh yeah, so the right elbow, this is looking at the joint, similar case to last time. So we're coming down the humerus. Here's the olecranon fossa. This is the fat pad within triceps tendon. And for the trainees, so the fat is sitting in that joint space and not coming out, showing that it's not a posterior fat, like a positive posterior fat pad. So essentially with this, I'm able to say there is not fluid in the joint. I don't know if this looks familiar to anybody. And I'll show you where I am. I'm in the anterior of the right elbow, sort of like this. I'll show it to you in a kid. And I'm essentially, you're like, what's going on? I want you to pay attention to right here. Okay. And so this is the left side. Here is the radial head. What's that? So this is more like in those newspapers when they're like, what's not similar? And essentially anybody see it? Use this clinically, see it, what I'm pointing at or no?
Yeah, Lei Chen mentioned radial neck fracture.
Nope.
Nope.
Is that a hook sign?
Yes. Who said that?
It's me. Well,
okay. And so I will show you what that is. And it's essentially right here. So Joni and team had first done this paper looking at 42 children who were all diagnosed with radial head, like nursemaids. And by that, how they were diagnosed was that they were all reduced successfully. So that was their definition of nursemaids. And they actually had like 17%, so like 1 in 5 of them have a fat pad on, a positive fat pad on ultrasound. So so then how do you use that clinically? Is that fracture? Could that still be nursemaids? And so there were 2 other papers I want to show you. So this is where they are. I don't know why they couldn't put a nice clean onesie on this kid, but so the linear probe is placed on the anterior surface of the anticube, and I do it all the time, and it doesn't hurt the kid. Even with nursemaids, it's actually really easily tolerated. And you're putting it in line, thumb side along the radius. Okay, and what does that look like? So on the top are normal images. So here's the capitellum, this is the radius, this is the annular ligament and the supinator muscle. And in a normal elbow, these things are outside the joint, lateral to the radial head. In the nursemaid situation, you are seeing the annular ligament pulled into the joint and the supinator muscle sort of comes with. And so as Will rightly pointed out, they call it, it's been named the hook sign or the J sign, and it's really clinically valuable. So there was a recent study that combined both things, because Joni's paper didn't look for the hook sign. And so they're looking both on the anterior elbow and for joint diffusion. And so again, very clearly, this is the hook, this is hookless. And so the big question for me is if I see, no, let me before that. So if there is a fat pad, and they call this hook sign the fringe. If there's a fat pad and no fringe, then they likely have a fracture. And if there's a fat pad and a fringe, then it likely is just a nursemaid's. So I use it in that undifferentiated elbow, they fell down, you don't know. From triage, often they order x-rays trying to be expedient. But I'll often look at that elbow, and if the story is unclear, you're like, I don't know, nursemaids, no nursemaids, and there's no swelling, and there's no joint effusion, I'll try and reduce it, you know? And so the way I use this is now, even if there was a little bit of joint swelling, as long as I don't see this hook sign, I would give it a go. So I was wondering if, I really love this. And I actually show this to the fellows, like even when I know it's a nursemaid's, I'm like, look, this is what it's gonna look like, so that even pre-reducing something so easy, I'll show it to them.
So Rosemary, in this paper, it looks like at least what, 40 out of the 200 of them were negative with both.
So
So you can even see nothing and give a crank on the elbow.
Yeah, exactly. So I think the biggest, the thing we worry of not wanting to do is crank on an elbow that may be broken, right? So I think that's how I can, that's how I'm helping. This paper didn't actually have as much positive fat pads as Joni's paper did. They said that, they're like, weird, I don't know why this other paper had so much more, but they didn't have as much fat pad being positive and it turning out to be nursemaids. Any other thoughts?
I'm also just a little bit curious how people's experience with this has been on different machines. We use exports in our ED, and I've tried looking for this and don't think I've convinced myself that I can see a hook or not a hook. So I'm
that kid was positive nursemaids?
I've done it on a couple, so you know, I don't know that I've been convinced either way, but it's probably lack of experience. But I'm just curious on other machines at other institutions if it's very clear or, you know, there's still some like ambiguity.
No, I mean, we use a zonary, and I mean, I usually can see it. Sometimes I can't. Basically what I do is I'll just scan the arm for signs of fracture. And if I don't see fracture, then I'll just try to reduce.
The other, Adam, the next time you for sure know it's a nursemaid's, I'd scan that arm. And then when you start to see it, it sort of pops out at you. I had a case where I had a 9-month-old sickle cell patient who came in for not moving his arm, and he looks like it's a nursemaid, but he's not moving his arm. So they were, and we were just doing a scan shift, and you know, they were going down the whole stroke pathway, scanning his head, doing all the strokey stuff, and I scanned both, and I thought I saw a hook on both, and I was like, oh man. So some kids there, I think there's a little bit ligamentous laxity. And I tried to, you know, nursemaids, I was like, wouldn't that be cool? I saved the day with POCUS and it's not a stroke, but he still was like not moving his arm. I was like, dang it. But so that was not a win, but sometimes I see it in another arm too.
As much as I hate measures in general, is there like a certain number of millimeters of intrusion or alignment with like the radial head that it has been mentioned in the lit at all?
No measuring. I think we're still at the this is cool factor.
Which means that it's ripe for another study.
Right on.
Rosemary, do you usually scan both elbows when you look for the hook sign? Because I've tried to find the hook sign as well on our Zanari at Cohen's, and I've when the story is good enough, I feel like I convince myself there might be a hook sign. But do you feel like that scanning both sides helps you differentiate sometimes?
Yes. Mhm.
Maybe splitting the screen. I thought about doing that once or twice, but haven't.
We're not that great of hookers at Cohen.
Right on. But I think, the next truly positive patient, just clinically scan them, and then you'll be like, okay, I get it now. So I think it's like learning how to do API from all the positive appendicitis that somebody else found. All right. So the next case is a 9-year-old African-American male who's coming in with a few hours of back pain and hematuria, and he has no other complaints. There's no fever, trauma, edema, no new medications, recent sore throat. And he reports sort of this like vague history of episodic bilateral flank pain, hematuria, and urinary retention. So pretty sort of focused / could be a bigger differential. So we decided to do a renal scan. This is on a scan shift, just walking around. Nothing too exciting over there. Left side. 2D. Anything exciting? No, nothing exciting. Not too bad. And we bladder. Is that? Perhaps, no thoughts, thoughtless.
It's cool looking, but doesn't seem to be shadowing.
No. And it does this.
It's swimming around on its own. Better not be.
Looks like it's having fun.
It is having fun. It's like sliding around. We made him move a little bit for that. So exactly right. We were like, when I first saw it, this intermittent, let me go back. When I first saw this, I was like, oh my God, this intermittent back. I'm like, he has a bladder cancer. I'm like, oh my God, the initial MASS thought entered my mind. But then I'm like, well, like you said, and then I'm like, is it a stone? Is it shadowing? You said no. And then we decided to make him move to see, and sure enough, it's having a lot of fun. So, and then the kid got into it and he started wiggling his body side to side to make it dance. And we were like, all right, kid, that's enough of that. And let me see. So then we're like, tried to make it twinkle. It didn't shadow. We're like, well, that's the reason for his hematuria. And he was going to go upstairs for a comprehensive. Anybody seen anything like this? No. So he goes up, he ends up giving us a urine that has a lot of reds, all his renal function, hemoglobin, everybody else is okay. And then he goes upstairs and like pees out, like I couldn't find a picture of a clot. And I told the resident to take a picture and put it in the chart and I couldn't find it. So this is the best picture of a clot that Google has to give me. And basically like a Goomba, like this big, and he peed it out in radiology. And after that, his radiology ultrasound basically says normal, and that was that. So he was, urology was consulted and they were like, good luck with that. I guess we don't know what's up with that. And his urine culture was negative. So the plan was to do nothing and just watch and wait and see. And then sure enough, a week later, he had the same thing happen again. And he actually went to the OR and was scoped. and they, went all the way up and put cameras this way, that way, and there was nothing. Everything was totally fine. And
Rosemary, has he traveled outside of the country?
no. Why? What are you thinking? What is that?
I'm thinking swimming in a freshwater lake somewhere in sub-Saharan Africa can give you schistosomiasis, but I've never seen one like this, even during my travels. But that's the only thing I can think of. But then they would have recovered some organisms.
Right. And schistosomiasis, like, so what is the thing swimming around? Is that the organism, or it's not, or it forms a clot, or what are you saying?
Oh, it's the organism themselves. I mean, it's
Ah.
supposedly, that's why you don't go swimming in freshwater lakes where there's snails, and or at least don't expose your urethra to the said water, because that's how they can get into you, and eventually that's how they leave, is through your urethra. It's kind of gross, but anyway, I'm not sure this is the case. Yeah, schistosomiasis is
No sub-Saharan African swimming, no. And so it's like TBD. I don't know what's wrong with this kid, but he didn't come back after the second episode. He didn't come back.
How old was he again?
9. So the other thing I think about sometimes, with sickler, no, he wasn't sickle, is sickle cell trait and, papillary necrosis and bleeding related to that. But he was born in this country. He was like, nope, I don't have sickle cell. And we're like, okay. So, but I haven't officially ultrasounded a papillary necrosis kid myself to see what that may look like on ultrasound. Have any of you? Negative.
No, Lee Chen also says IgA nephropathy. That's his own thought on the chat.
Yeah, gross.
random thought.
Yeah, this is like a clot in his bladder, so that's a little weird. All right, moving on. So I have a 15-year-old female with 3 months of mild abdominal distension and pain, presenting with 2 days of back pain. She hasn't had her periods yet. She's not sexually active. She complains of some urinary urgency, and she has a firm, full abdomen that, could be qualified as several weeks uterus. So obviously the differential in this girl is wide open. I'm going to just show you the interest. The long axis. There's some chatter on the chat. What are you guys thinking? The answer in the chat. And then
we're saying giant ovarian cyst, hematocolpos on the differential.
Right on. Yeah, so the thing was so big, we couldn't even like get it on one clip. And yep. And so sure enough, it actually turned out to be hematocolpos. And on everyone's history, they didn't see any like protrusion from the vaginal whatnots, but when GYN got involved, I guess they really got in there. So they got some more history, and she's had back pain for 1 week, a month for the last 3 months. And then they noted some bluish bulge and tinge under the urethra. So it was like a Friday afternoon, and in our institution, like there's only specific people who do peds GYN, and if they're not on call, then surgery sort of does it. And ultimately the decision was she was discharged home because it'd been going on for months and her belly pain wasn't that bad, and we had a diagnosis. So she actually came back 2 days later on a Monday to be admitted to go to the OR. And so she underwent the hymenectomy, and they got 1,100 of like clotted blood basically from the vagina. That's always fun.
I have a question somewhat related. Do your institutions, so at our institution, OBGYN makes us get an MRI looking for other GU abnormalities, which I don't know that we found a lot of those, but that's sort of, they are insistent that we have to MRI these kids before they will intervene.
No MRI.
When there's a bulging blue and purple hymen, they want an MRI still?
Adam, yeah, no, I know but this is sort of become almost protocolized that they won't, because they're looking for, I guess, other, and I don't know, sort of sort of what other GU abnormal, not even GU, but sort of, I guess, even sort of sex, sort of differentiation, but they're insistent that we have to get MRI.
I guess there are cases of bicornuate uterus or something, but they would present differently. I mean, they may even menstruate normally from one side, but not the other. But I agree with Adam's incredulousness. Yeah.
Well,
even
it's not
ultrasound,
only,
like a comprehensive ultrasound wouldn't be good enough.
Yeah, no, they insist on, because oftentimes, so we'll see these, on point of care ultrasound, they'll end up getting their radiology ultrasound. And then we have to go on to MRI, and then they send them home. They sort of, I guess, similar to, then they say, if it's just hematocolpos, this isn't an emergency, and they bring them back in for sort of a scheduled operation.
Kate, in our institution also, they've requested MRIs.
Yeah, I'm just curious.
But,
Yeah, sort of. Yeah.
All right.
My son, they went fine. Interestingly, mom had actually had it as well. And once we told her, she's like, "Oh, do you think it could be it?" We're like,
That helps. All right. So next case, we have a 13-year-old female with epilepsy and chronic constipation who presents with sharp abdominal pain of one day. So left lower quadrant pain, it's constant, not radiating, there's no fever or vomiting. And her last bowel movement was 2 days ago and was small and hard. So her prior history, she has a right ovarian cyst on CT 6 months ago from somewhere else. And her LMP was 3 weeks ago. She's not sexually active. And she doesn't have a peritoneal abdomen. And she has left lower quadrant pain on palpation and no masses. So again, that female pelvis is waiting for a big diagnosis. And then I'm coming on at like 7 a.m. and they have been waiting to fill her bladder to do ovarian ultrasounds. So I'm like, you know what, by now it should be full. I'm gonna go look. So this is the right side, no color. Wait, yeah, long and transverse. So giant bladder for sure. I see an ovary there. And this is the right side that I saw an ovary there. So chocolate chip cookie, etc. But the interesting part is, sorry, what just happened? Let's try here. So as I'm scanning the left ovary, so now this is almost in transverse. Here's the left ovary. This is the uterus in cross section. And I was sort of puzzled by this. This like dilated tubular structure that was lateral to the uterus cross section. Like right there. I'm like, what is that? Because it was separate from the ovary, which was much higher up. And for sure she has stool sort of compressing like her entire abdomen, basically. Thoughts? Any thoughts? People seen things like this?
I think that was a hydrosalpinx.
Yeah, that's kind of what I was going with. I'm like, it's a tubular structure lateral to the uterus. We finally let her pee because the way, and you guys let me know. So for testicles, you know, for sure, I would always do a comprehensive regardless of whatever I found. But for ovaries, I feel like if they are not large, and I clearly can identify them, then I don't feel like it's torsed. And then I potentially may not do a comprehensive. So I let her pee. That was negative. She did get an enema in the ED because she had a lot of stool, and her pain improved. And I decided to let her go and say this was hydrosalpinx attributed to severe constipation. And this was, I don't know, a year back or so. So, and I look back, she hadn't come back and nothing terrible has happened. So I was like, I guess that happens, just as it can obstruct the bladder neck. I'm sure it can compress other structures that are sort of in the vicinity. What do you guys think? Is that crazy? Should I not do that?
Yeah, I mean, for me, ovaries are harder than testicles, I think, because the testicle, for the most part, you know what you're imaging, but in the pelvis, things get a little bit more complicated to my liking. And with the dual blood supply, I agree. I feel like if you do a screening, POCUS, and there's clearly like an abnormal lesion or something heterogeneous, and you know, you can sort of flag that and move on to the next step. But I personally am fearful of you know, sort of ruling out something like a ovarian torsion when we know that even radiology, I think, has a difficult time just based on the challenges of sonographic diagnosis for that condition. So, you know, cool clip. I guess it's probably the fallopian tube. I don't know, you know, without landmarks and a story for PID and things like that. I'm not sure, but I'd welcome to hear what other people think.
No thoughts.
I agree. I know. I'm in your same boat. I think I would have, if I seen that, I would have probably comprehensive and seen what their thoughts were. So, you know.
All right. I think I'll show you at the last case of my humility story. So I have two more, and she is a 4-year-old female who presents with 4 days of diffuse abdominal pain. She has BMs every day, but sometimes they're hard. And no fever, no vomiting. She was seen at the pediatrician's 3 days ago, diagnosed with constipation for the same. And the recommendation was for dietary modifications. They didn't actually even do Miralax. And then now coming to the ED with worsening abdominal pain. And just randomly, mom mentions that she had high blood pressure at her well child visit 10 days before, and that was attributed to anxiety. And then the repeat BP at a week later was normal. So those are her vitals. She has a benign abdomen. And this is like in the thick of winter. And the resident is thinking she is also constipated, but she's febrile now, right? So it gets a little bit more complicated. You know, UTI gets into the mix. We didn't have suspicion for API based on there wasn't really any right lower quadrant tenderness. So the plan was to get a UA and give an enema, Tylenol, and then repeat the blood pressure. So her UA was not as exciting. Sure, there were some whites. We're like, is that the reason? And she had a large stool ball with the enema, and her pain improved. And her vitals, she defervesced, and her blood pressure was still a little bit on the high end. And at this point, the resident's like, she's ready to go. And, you know, this was like, to set the scene. So it's winter and it's like pandemonium. I can't remember if it was the beginning of, I think it was the end of my shift. And we're like hallway patients at this point, and the kid is in a stroller at midnight and asleep. And the nurse is like, all right, I got the discharge papers, we're ready to go. And I was like, that's when I finally got around to talking to mom. And I was like, okay. So with this blood pressure story, the belly pain, I was like, you know what, I'm just gonna look. So this is the left side. Kidney, nothing too remarkable. Is the bladder, long axis. So when I saw this, I like, you know, we try and maintain our composure, but I visibly sighed. I actually like let out a sigh, and mom was like, what was that? Why'd you sigh? And I was like, oh, God. I was like, so we're like, nope, this is not constipation. You guys see what I'm seeing? So this is not normal kidney architecture anymore. So the kidney, the lower pole you can see, but there is some sort of obvious space occupying mass that abuts the kidney slash is from the kidney. So she ended up having a CT scan. She did a radiology ultrasound first, and then had the this by the end of that ED stay, and that was the large renal mass, likely consistent with Wilms, with no evidence of lymph nodes or Mets, and there was some concern of maybe a thrombus in the. Turned out not to be the case. So she was admitted, and 2 days later, she underwent a nephrectomy with favorable histology, and then she, you know, did all her treatments, and 2 years later, she's in remission and doing well. So, you know, in the spectrum of when I think back to, you know, if I've helped anybody or, you know, saved anybody's life, like I don't feel like I've really done anything except this kid. Like I will always remember this kid. And I feel like, you know, for the trainees, you know, what's the big deal? I always sort of look because you never sort of know what you're gonna find. And for her, it was the little blood pressure thing kind of stuck in my head, and the belly pain, not even the fever so much. And you know, in our ED, like so many kids are hypertensive for pain, for anxiety, for, you know, so many reasons, but something about her, the fact that when she was at her pediatrician's and that mom sort of remembered to say it, I was like, that made me look. Thoughts? No thoughts.
That's a great catch, Rosemary. That's a great case.
Like, honestly, you know, for all our resuscitations, all the stuff we do, I mean, sure, we might help people, but, and I'm sure that she would ultimately have come back with something, you know, it would have not been a silent thing, but catching it early and I think listening and, you know, we all have these extra skills that you know, the heebie-jeebie feelings on our neck that we should sort of honor and go the distance. So I always appreciate it. All right, we're gonna end with the last case, is a 15-year-old who came in for 3 hours of right testicle pain. You know, we were gonna end with this after our prior conversation a couple of weeks. 2 weeks, I'm sorry, 2 episodes of emesis, and this is like at 1 in the morning or something. He woke up and he was puking. And he had been working out with his dad earlier today, lifting weights and running, but that's basically it. And on exam, I only have the symptomatic side. And on exam, he for sure had a testicle that was horizontal lie, no cremasteric reflex, tender to palpation. So it was screaming torsion essentially. And this is his right side. Just scanning. Don't think I got a clip of the left. So I put color on. I'm like, and so for trainees, like you really need very low flow settings for your color because testes are low flow state. So if you have the color turned up too much, and you're like, you can falsely say, oh, there's no flow there, but looking and staying very still with your probe so that you don't create artifact motion color. But really, I'm like, really, there's no color? Are you sure? Yeah, I mean, I expected there not to be, and I don't see any uptake within. And this is not my image. This is from our radiology tech, but this is the most sensitive and specific sign, this whirlpool sign, and it is the spermatic cord sort of twisted on itself. And when you put color on, it does this whirlpooling. So when you have that, it's pathognomonic, you're done. And just a word on the pathology. So it's altered blood flow, right? First venous goes, then arterial. And incomplete torsion is less than 360 degrees turn. And so there may be some arterial flow that persists. Complete is the absence of flows to the testes, the epididymis. And so there is generally increased volume from all this congestion of the testes and epididymis. And early on, those first 3 hours, the testes really looks very homogeneous. But then later it becomes more heterogeneous. So when you see irregular architecture, it doesn't portend well. So the hypoechoic areas are necrosis and the hyperechoic areas are hemorrhage with potential reperfusion. So a word on detorsing. Relative contraindications are symptoms greater than 6 hours. And so this is where I think historically the sticking point is that most of the time, 70%, I want it to be 90, but 70 is usually the testicle is twisted medially on either side. And so to detorse, you elevate the testicle, and you really have to get on the other side. Matthew's going to make fun of me for my hand gestures. So I'm going to try and hold my hands. So you really need to be on the opposite side of the patient, because you really, it's sort of like the overhand grip for the subxiphoid and or the apical four. Like you really have to get your, like not be limited by your hand. So left testicle requires your right hand. So you want to be the opposite side. I mean, you can imagine using the same side, you can't really twist. And the same for the opposite side. So I have done it. And so doing it 180 at a time and reassessing, and success rate seems to be pretty crappy for the paper I looked at, but resolution of pain and normal anatomy is sort of your end goal. And I'll tell you my conversation with urology. And given our last discussion together about what the concerns of detorsing ourselves might be. So this is after 180 turn. And no, I'm like, I don't think so. And this is after another. So after the full 360, and there's flow. And he feels better himself. He's like, oh, and he's like actually relieved. So then I look for a vessel, and this is continuous. So that is venous flow. And found another vessel, pulsatile arterial flow. All this sort of happened within like 5-6 minutes, and then radiology was ready for him upstairs. And he went upstairs, and they said hyperemia, compatible with intermittent torsion. That night, so this is like now 3-4 a.m. We called urology. They didn't actually come in because we had detorsed, and they actually offered the patient outpatient orthopexy. And given our last discussion, I asked one of my urology friend colleagues, like, should I not be doing this? Like, is this like bad if I do it? And what is the concern that could I? So theoretically, he's like, the reason why it's because it's the 70%, right? Like, and because we have the access and the capability and the buy-in to be able to get the ultrasound stat, get urology in-house quick, get the OR prepared, that our culture is to detorse while physically looking at it, so how many twists, and that you're not making it worse. But I was like, could I really make it worse though? Because if you guys are coming in anyway, like it's not that much longer. And he's like, well, it's our culture. So the way I would sort of, maybe I would be more cautious going forward, or I would educate the family like, hey, this may work, but in the short term, there's a small chance it could get worse, but you'll be going upstairs pretty quick to get this sorted anyway. And or in a snowstorm, and or in a community hospital where it's going to take, or there's no, peds ultrasound there, or it's going to take, getting from this place to that place. So he said that if there are factors for delay, then, you couldn't be faulted for detorsing, but in our institution, because we have the system in place, that's our culture. So that's where, so I'm going to think about it a little bit harder, I guess, the next time I want to do it. Thoughts?
Hey, I wanted to know what incomplete intravaginal torsion means. Does that mean it's still torsed after your detorsion?
That's what I couldn't quite get. I don't know if it's that it was like lying sideways. I'm like, what does incomplete mean? And I read this to radiology and they're like, oh, that's fine. And I was like, what? Okay.
And did urology come in to see the patient or did they do a phone consult? Like
Phone consult. Phone consult, and they talked to their attending. Yeah. I was like, please talk to your attending.
yeah. Very cool cases.
Great cases, Rosemary.
Yeah, Rosemary, thank you again for presenting.
Yay. All right, everybody. Have a great day. It's good to see you all.
All right, see everyone next week.
Oh,
Bye.
bye-bye.
Hi, guys.